these are my conflict of interest, but let's move quickly to the summary of my talk. We will firstly talk about the limitation of PSMA, then go through the accuracy and prognosis information that PSMA could give, and then the influence of PET PSMA on treatment decision, and then some conclusion, very quickly. So first, you have to remember that despite its name, PSMA is not specific for prostate cancer. And here you can see highlighted the fact that even renal cell carcinoma, for example, that you just heard, overexpress PSMA, not at the same level of prostate, but overexpress. This is not necessarily a bad news, because sometimes in the clinical practice you might also use PSMA. And secondly, that many benign conditions might overexpress PSMA, and in particular all the hemangiomas, vertebral hemangiomas, splenic hemangiomas, and so on, neovasculature, and some benign bone conditions. So keep in mind this. But it's not over, because PSMA is also not overexpressed in all prostatic cancer cells. There is a very large variability, even interpatient and intrapatient. Okay? For example, you see there one single patient with one lesion that largely overexpresses PSMA, and the other one that does not overexpress PSMA at all. So another limitation. Let's move quickly to the accuracy of prognosis. Let's start from the milestone paper. You all know about this paper. I don't want to bother you about this. This is the PRO-PSMA trial. It's the first randomized trial in imaging that is relatively infrequent. It's not so frequent to have randomized, prospective randomized trials in imaging. You know all very well the results. The results say that PSMA has a better accuracy than standard of care or standard conventional imaging, has an impact in 30% more or less of the patient, and the authors suggest that CT and bone scan should not be performed anymore. This is not always the case, but could be replaced by PSMA. After that, the European Association of Urology, they started to insert PSMA in their recommendation. As you can see here, from 2020 and 21, they did not mention PSMA at all in the staging of high risk, and then in 2022 they start to mention PSMA in staging high risk, but with some disclaimers that I don't want to go deep into detail. Up to in 2024 and 25, where they suggest PSMA in the staging procedure of high risk localized prostate cancer with a strong evidence in high risk and with weak evidence in intermediate risk. So keep in mind this one. And this is why, because I present very few papers, but there are so many papers and very well-designed papers. This is one of them that assess that the PSMA, and this is the mantra you will ever listen or you already listened to, had a low sensitivity in nodal detection, but very high specificity in nodal detection. That is the key function of PSMA. This is one of the first very well designed and with the histopathological result as gold standard. So sensitivity 40%, very low, but specificity 94%. And this has been published a few weeks ago. This is the largest review of the literature ever published on PSMA on 18,600 patients. Is a review of the literature, but in a subgroup of patients where the validation is not weak, but where the validation is with histopathological results, you see that this data is absolutely confirmed. So sensitivity about 50%, specificity 94%. We have to be aware, because this specificity is a little overestimated, because we are dealing with a population with very high risk of lymph node metastasis. Okay? So they are not patients that walk in the street. They are patients with prostate cancer, so it's easy to have a good specificity. And the authors conclude that, of course, PSMA should be incorporated with the nomograms to inform treatment decision, and that is what I will try to show you in the next papers. Moreover, has been assessed very clearly now in many, many papers. Again, I just show you 2 or 3 of them, that PSMA has a strong prognostic value. On the left, you see one paper, very nice paper, 230 patients, and you can see that if you are an high-risk patient with N0, your biochemical relapse-free survival is better than an intermediate patient with N1 at PSMA, independent from everything else. So very strong prognostic value. And this is the follow-up of the patient of pro-PSMA study. You see that the patient, the study was prospective, so they follow up the patient up to 54 months, so many years. And you see that there is a significant difference between the biochemical relapse-free survival in patients that were N0 versus patients that were N1. After 3 years, N0 were 70% free from relapse, while N1 were 46% out of relapse. So let's move to what can we do to clinicians? How can we help clinicians? Because this is absolutely theoretical. Now we want to put it in the ground, in the field, okay? So these are the options that you know better than me as a clinician that you have to treat high-risk localized prostate cancer. You can do radical prostatectomy, and this is a suggestion by the EIU that say if you do a radical prostatectomy together with pelvic lymph node dissection, this should be extended. This is not always the case, we will see later. And then if you want, and the patient is fit for, you can use image-guided radiation therapy to guide the radiation therapy if the patient is addressed to radiation therapy regimens. This is not mandatory, but is suggested. And then we have the elephant in the room, the big problem, the N1. You know better than me that in a significant percent of patients with high risk, they enter in the PET center with high risk, they go out from the PET center as multimetastatic. This is relatively frequent. This is more frequent than we might expect. But the problem is that up to now, all the nomograms or the suggestion, everything is done on bone scan and CT. So we are dealing with a population that is completely different from what it will be in the next 3, 4, 5 years. Okay? So how can we help clinicians? First, in the T status, very little help, because we can sometimes integrate the MRI information to assess if the seminal vesicle is invaded or not, but relatively small indication. We can help MRI, together with MRI, we can help radiation oncologists to focus the treatment on the prostate, but we can identify N1 lesions and potentially guide pelvic or extended pelvic lymph node dissection or guide a radiation therapy. Or we can identify N1A or B, potentially address the patient to the correct treatment according to the volume or the location of the disease. And of course, assess the volume of the disease and address the patient to the right treatment. And we were talking about extended lymph node dissection. You know that this is not always the case. First, because many patients are treated not with the pelvic lymph node dissection. Second, because pelvic lymph node dissection does not remove all the potential positive lymph nodes. There are some blind regions that are not removed even with the extended pelvic lymph node dissection, especially in the presacral area, in the pararectal area, and very close to the aortic bifurcation. And now we will see some cases. This is, I hope you see clearly, yes, probably. This is a very recent case. This is a standard patient. You can read the story of the patient in the upper left corner. However, is intermediate unfavorable risk, underwent PSMA PET before scheduled radical prostatectomy. As you can see, standard lymph node, but also one lymph node in the presacral area. As you can see, the contrast of PSMA, even with the very, very small lymph nodes. So another case, this is very typical, again, Lymph node, very small, subcentimetric lymph node in the pararectal fat. Again, look at the contrast, very easily detected by PET PSMA. Another one, this happened very few days ago. This is not something that is in our repository this is something really that happens every day. This is another weird location because this is a common iliac lymph node. But where the common iliac lymph node is located is behind the vase. This is potentially a problem for the surgeon. So you have to inform in your report that this lymph node is exactly located there. Again, and then, as we said, PSMA is not specific, but also we might have some false positive. And this is the case. The same patient had a very intense uptake in one rib lesion. This one rib lesion was intensely uptake, you see, but it's probably related to fibrodysplasia. That is a very well-known condition that might cause false positive findings. However, this patient was addressed to radiotherapy and androgen deprivation after PET. And then, this is something that happened relatively frequently. Again, this is a patient with already very high-risk disease. MRI was already IPIRATS 5, did already detect some positive lymph node in the pelvis, but correctly, they did not stop the staging, and they addressed the patient to the whole body staging in any case. Why? And they were right, because the patient showed many bone lesions outside, all of them in the vertebra, let's say, or the pelvis. So, and this patient was lately addressed to triplet. This is a point for discussion in the discussion section later on, maybe on, because they interpreted this as a de novo high volume, and they addressed him to triplet. But I want to underline this. Look at the CT component of the PET. Do you see anything? No. Do you see how intense is the uptake in the PET PSMA? So the sentence is that if the CT findings is negative, it means that it's not positive. Absolutely forget about it. There's nothing to do with that. Okay? And even in this patient was the bone scan negative. Why? Because the alteration of the bone was already maybe too initial or too small to be detected by bone scan. And then image-guided radiation therapy. How can we help? We have a little bit in the prostate, because we can integrate the information of MRI to better define the GTV, for example. But the most important information we can give is to N status, N or M1A status. There are many trials ongoing. I cannot show you the results, but this is one of the many trials. This is probably from Belgium, where they use PET PSMA at presentation to include or not include the lymph nodes, the positive lymph nodes, and to increase or not increase the dose they administer. And they say something in the conclusion. They say that we want to see if changing our approach according to PSMA in the PSMA era. And this is very interesting, and again, another point of discussion later on. This is a very recently published paper of a Dutch group where they asked this question to 40 urologists. And you can read the question probably. Would you perform a PET PSMA in intermediate favorable risk? Would you perform PET PSMA intermediate unfavorable risk? Or would you perform in high risk? Look, 100% they say they would perform in high risk, almost 100% in unfavorable risk, and 12% in low risk. I agree with that. But the important thing is that nobody will do, again, CT or bone scan. They all them answer 0. I'm not sure it's correct or not. Again, another point for the discussion. But they interpret that if you have available PSMA, there's no reason to perform a CT or bone scan. This is questionable. It's a point for discussion. And then the other point of discussion is this one. This is a very recent case, like a few days ago. Monday, I think. Yes, this patient with the Gleason 8, positive biopsy. The PET is negative in the prostate and is negative in the lymph node. Would you perform a pelvic lymph node dissection in any case in this patient? extended, not extended, would not you perform a pelvic lymph node dissection? This is another question they answer in the conference, the consensus conference group, and this is, you can read the results. 30% would not perform pelvic lymph node dissection in a case like that, and 40 in intermediate risk. However, again, it's another point of discussion. And this is my conclusion. So PET PSMA is not specific, it's heterogeneous, and has a low sensitivity on N1, but nowadays is by far the treatment, the imaging of choice in prostate cancer. Why? It has an impact on treatment strategy, and it has a significant prognostic value. Thank you very much, but this is my real conclusion. En español, esto no puede pasar más. Esto es un paciente que es un high risk estadiado con CT hemoscan negativo. Esto que pasa 2 meses después. Esto en 2025 no hay que pasar más. Esa es mi conclusión personal.